Thank you very much to all of you for having me, and thank you, Mr. Hurst, and also David for introducing me, and all of you for doing the good work that you do. I hope that there's the equivalent of Prescription for Progress in multiple communities around the country. Certainly the epidemic and the urgency of it would imply that it is a good thing to do, but my guess is that you're one of the most effective groups, and I hope that you are cloned everywhere, because the challenge is, I'm sure you know, probably better than I do, because I know some of you are frontline combating the opioid epidemic today. You know better than I do just how tragic this epidemic is. So I'm just going to cover two things. I'm going to try to do it in an efficient way so we have time for questions. I'm going to give you the top of the trees of the report that you cite in your notes that I see here being handed out, which is the Association of Schools and Programs of Public Health report, bringing science to bear on the opioid epidemic. We met for well over a year, but not two, trying to put together the best set of succinct recommendations for multiple reasons. We felt that there would be a message in all of the schools and programs of public health, of which there are about 200 in the country, coming together in a single voice and saying what ought to be done. And second of all, I had suggested the creation of the task force because it was becoming obvious reading the papers that one way or another, for good or for ill, there would be some kind of a settlement. And having lived the settlement of the tobacco industry that resulted in about 95% of the money going to everything but the problem, I was acutely aware of the risks that might lie ahead, and I still think those risks exist. I won't have time to describe the experience I had leading the first foundation created out of the attorneys general involving a settlement with an industry, but I will say soon after launching our public education campaign and them getting an inkling that it was working, we were in court. So it was swift and sure. So the association report was led by this group. It was chaired by Robert Pack from East Tennessee State University College of Public Health, one of the epicenters of the epidemic, and a stellar group of people who know an enormous amount about the problem. I ended up on that not because of my history in working with opioids per se, though I did spend 20 years in the AIDS epidemic, and I have done research among those who are addicted to opioids. I was there because of my history with the Master Settlement Agreement and the sense that this could become a factor. We had further individuals involved as ex officio, and of course a great staff at the association. So we had a charge, and it was to identify and define evidence-based public health initiatives for the prevention and treatment of opioid use disorder, the mitigation of other consequences of opioid use, and in consideration of related and emerging substance abuse problems that may be undertaken with revenue resulting from litigation brought by public sector entities. We listed the entities against opioid manufacturers and distributors, and we had a mandate to demonstrate why such approaches are essential and how they complement other initiatives that are out there. There, as you know, are headlines all over the place. Everyone has their sense of what the priorities should be. Many are talking about what a settlement might look like. There are endless headlines about the suit and who's responsible, and is it the pharmaceutical industry that's solely responsible, or is it physicians in the pharmaceutical industry, and is it the FDA because they didn't step in and regulate when they should have? And I will say that I had an opportunity to present this report with my colleagues to the full body of ASPPH, and I was one of the early speakers, and I came away from the podium and I did this. We're all responsible. And I believe that. We're all responsible because somehow we went from an epidemic that had about 2,000 deaths a year, which was pretty much what it had been for a very long time, to 70,000 in 20 years, and no one said anything. We are people said something, but this didn't happen, what's happening here. It was late in happening. It snuck up on us. And while I have a sense of those who are principally responsible, we all get to own a little bit of the blame and the shame that it happened at all. And I think you probably all know that we've just passed the 4th year of US life expectancy actually falling. The last time that happened was in the flu epidemic of 1918. The flu epidemic of 1918, not wanting to scare you all, killed 500 million people at a time when the population was 1.9 billion, so 1 in 4 of all the human beings in the world. So that's a real epidemic, and it managed to turn down the life expectancy of the entire world. This epidemic has contributed, not solely, but it's heavily responsible for the downturn in the life expectancy in the United States of America. So it's a big deal. It's almost exceeded the total death toll of the AIDS epidemic. And there's a paper that's going to be coming out fairly soon that's going to contrast the deaths, opioid deaths in the U.S. to the rest of the world. I can't give the figure, but when people see it in the headlines, it's going to be alarming and concerning for all of us. So we have a mess, and you're here helping to fix it, which is extraordinary and extremely important. And there are hundreds of people like you from every walks of life trying to fix it. And then there are people who are just trying to look at all the data and understand what the patterns are and figure out what does it mean and how can we solve it and what's the best approach. So we probably literally reviewed every major study that was produced on this subject by this committee, and we tried to distill it into the most important actions to take. As we were doing that, I had a paper come out in the New England Journal of Medicine that contrasted the tobacco settlement provisions with what might be provisions in a opioid settlement. That same paper also contemplated settlements with carbon producers, with alcohol producers, with the fast food industry, because we do have a handful of industries in the United States of America whose products actually do cause a fairly burdensome amount of death. To be specific, if you add up about the 6 top industries whose products are associated with loss of life in the U.S., it's 826,000 deaths, which is approximately 32% of all deaths. So and it's actionable. It's not eradicatable. You can't stop them all, but you can take really great actions. So looking at the opioid column, and this is just illustrative. It's not intended to be, oh, this should be the settlement, but it just shows the contrast between what was in the tobacco settlement and what could be in an opioid settlement, regardless of what level of government it was undertaken by and who actually implements the spending. The science base, you can't win these, you cannot get a settlement if you can't prove blame. You probably, there are lawyers in the room, you realize that. That is a challenge for some problems where it's hard to prove blame enough to motivate those who produce a product to come to a negotiating table and settle. Anybody who's been in a legal problem knows you don't settle if you are certain that you are innocent and there's no proof that you're guilty. So the science base has to be there, and it is there for opioids. There has to be a mechanism to improve the situation from what it previously existed. And in the United States, a lot of the things you would want to be changed can only be changed voluntarily. Most importantly are restrictions on advertising. Commercial speech. Commercial speech in the U.S. is generally treated the same as free speech of an individual, which is quite different than many other countries. So in the settlement agreement, the tobacco industry agreed not to advertise anymore, not to have Joe Camel, not to do X, not to do Y. They could not be forced to do that by a court. And if there had been an effort, a law passed to force them to do it, they would win in the Supreme Court. And right now, if you notice, when you're in a drugstore and you look at a pack of cigarettes, you have the same warning label that was put in place in the 1970s as part of a deal between the industry and Congress for the United States to stop public health advertising against tobacco as a product in exchange for them putting a rotating warning on the package. It wouldn't be there if they didn't agree. And so we don't have the kinds of graphic warning labels that other countries have because thus far the lower courts, and they know the Supreme Court will not sustain them, even though there's pretty strong evidence that they work. So public education, there is a great deal of discussion going on that any kind of a settlement has to do something, and I'm sure people in this room totally get this, have to do something to change the mindset of the United States of America, destigmatize the reality of addiction and how it affects, millions of lives in this country, and also engage in targeted advertising that re-educates healthcare professionals about prescribing and also primary prevention for young people so that young people understand the dangers of becoming ensnared in opioid use. You probably know that there was a complex system of organizations created by the pharmaceutical industry to solve the pain problem. Very analogous to the tobacco council that was created by the tobacco industry to produce fake science to counteract the true science that was coming out of universities and laboratories. The settlement agreement with tobacco shut those down. This settlement agreement has to shut those down. And that, too, can only be done on a voluntary basis. So I'm just choosing a few examples. Labeling and warning. Very hard to force a company to put a warning label on its product. It can choose to put one on its product. FDA can require it because it's directly related to something the FDA knows about the drug. But otherwise, you need the company's approval because it's, again, in the category of compelled speech. So there's a lot of work to be done in a settlement if it's going to really be one that has teeth and really has public health impact. So we had some foundational principles for our group. Opioid crisis is a public health issue, not principally a criminal justice issue. Obviously, it's tangentially a criminal justice issue. Addiction is a chronic, relapsing brain disease. The opioid crisis has both social determinants and corporate determinants. When I made that statement, someone said, corporate determinants is part of social determinants. I said, you're right. But do people really, when they hear about social determinants of health, think about big bad corporations who don't care who they kill? Most people are not thinking about that. So let's actually say it so they don't lose that thought. Recommendations need to be aligned with the guiding principles of public health. We have to give consideration to the syndemics and synergistic epidemics related to this epidemic. As you all know, resurgence of HIV infection and the like. And the scale of the synergistic epidemics demands a multi-pronged public health approach, and I think this is the most important recommendation, not unlike the Ryan White Care Act. So anyone in the room who has had any historical involvement in the response to the AIDS epidemic in the United States knows that about 5 or 6 years into the AIDS epidemic, a series of categorical separate programs were all brought under an umbrella for a federally driven and state and city collaborated with program to pump large amounts of resources in a coordinated way into every state and locality based on the impact of the epidemic in that region. It was named after Ryan White, who died of hemophilia acquired HIV. We need something very similar to combat the opioid epidemic. And in doing so, we can build on the wonderful building blocks that already exist with Ryan White, because that epidemic has a lot of similarities to this epidemic, particularly as it relates to those who were infected through IV drug use. So the recommendations are, expand the evidence in epidemiology, undertake an anti-stigma and harm reduction campaign, engage in primary prevention, which is in public health, means stop it before it starts, ensure access to appropriate medications for opioid use disorder. That's a major problem area. My vote is that every pharmacy involved in these scripts has to open up a medically assisted treatment unit right in their pharmacy. In Germany, this is a very unusual recommendation. It was removed from a paper I have in press because I'm sure they thought it was very much off the wall. But I think it's spot on, because in Germany, in every area, small area, maybe a 4-block radius, 24 hours a day, 7 days a week, there's a pharmacy where you can walk in and get a clean needle exchange. We don't have that in the United States, and in fact, if you try to do it in the United States, people will be out in the streets saying, you mean you're going to let IV drug users walk into the corner CVS on my block? No, forget about it. So this is why an anti-stigma campaign is necessary, because we now have an epidemic the same size as the AIDS epidemic in the United States, with very few signs that it's truly abating. There are some, and we should be deeply, deeply, deeply concerned about the direction that it will go. And in order to do that, we have to massively make available medically assisted treatment for those who have opioid use disorder. regulatory and legislative reforms, I've talked about some of them, and changes in the industry business practices, which are already happening. So the public health community and its partners need to be equipped with the necessary data to understand the size, scope, and location of the need of the opioid epidemic. The recommendations in this area will help us to improve metrics, standardize systems, leverage technologies and tools, and share and analyze data to combat the epidemic. And epidemics don't stay in one place, you all know that. They move around. I like to call them volcanoes. They simmer, simmer, simmer. They let off a little smoke, and once in a while, as happened here, they explode. This didn't just naturally explode. It had an accelerant, and it has exploded. And we have to use everything we've got, including all the people in this room, to turn it around. The task force feels strongly that opioid use disorder is not widely understood as a medical illness, so reducing stigma around this problem can improve access to treatment and harm reduction programs. These recommendations are directed at educating health professionals and the public, reducing barriers to medications for OUD, promoting recovery, and spreading evidence-based harm reduction programming. That's a euphemism for injection sites. And that's something that people are very uncomfortable with, but not having them is killing people. And it could be your family member. Primary prevention and strategies for preventing opioid misuse are critical to stopping the epidemic and should be focused on youth and the public at large. Primary prevention is what we did at the Truth Campaign. It's now called the Truth Initiative. We spent more than any other entity spent to change the mindset of young people about tobacco. We did it with very graphic messaging that created an alternative brand to the tobacco brand. The brand was rebel against people who are trying to hurt you. That was the counter brand. And young people are rebellious, and the brand worked phenomenally well so that young people, rather than looking at a pack of cigarettes and say, oh, I'm going to be a grown-up, they thought, oh, those nasty people, what they're trying to do to me, what they've done to my aunt, what they're doing to my father. And that's what they should think, because they're victims, especially when they're young and you're sowing the seeds of addiction in their bodies to last a lifetime. So our first ad piled body bags around Philip Morris's downtown headquarters in New York City. It was a special day for Philip Morris. They were not happy. They called Mayor Giuliani and they asked that he please take definitive steps to pull our permit to shoot the ad. I was working 2 jobs. I was associate dean at Columbia University, and I had already accepted the CEO-ship. So I was going back and forth between New York and Washington. The deputy commissioner of the health department called me and said, you've really upset a few people, Cheryl. The mayor just called and wants to know who you are, what's legacy, and should he pull your permit? And I told him who we were and what we were doing and why we were doing it. And I said, please don't pull my permit. So he called up Mayor Giuliani. You'll love this story given all that's going on right now. And allegedly, the mayor said he thought that was a really good explanation. They were called back and told, we're not pulling the permit. As a matter of fact, we're going to send some police down there because now you've got us concerned since you're so unhappy. And the response to him was, we're going to leave New York City if you shoot this ad in front of our headquarters. He said, fine, I'll come help you pack. That's the old Giuliani. And they did leave. They moved in about a year to Richmond. So Philip Morris USA is now in Richmond, Virginia, because they didn't like 1,200 body bags piled around their downtown headquarters. So credible prescriber and dispenser training created by an independent organization. So we have to re-educate our health professionals and our pharmacists. Academic detailing, which is the antidote to pharmaceutical industry detailing to enhance training for healthcare workers and help to correct the inaccurate and misleading statements made by drug manufacturers. An expansion of safe drug disposal sites. Facilitate local access to medically assisted treatment for those with opioid use disorder, hence my Germany model. Every CVS, every Walgreens, just walk right in and get your medically assisted treatment. I am planning on calling the CEO of CVS. I was at a big gala for a drug treatment program which will be unnamed because of what I'm going to say. I sat down, I was excited. It's the 15th time I've attended it. It's a very credible organization, and I opened up the program, and that particular CEO was receiving an award for his work to combat drugs and I found it a little alarming, to be perfectly honest. But it made me think that my crazy idea about let every pharmacy provide PAs and even pharmacists who can be trained to treat this disorder and have a place for everybody to go in every hamlet in America from coast to coast actually is not a bad answer at all. Re-regulate bupropion prescribing, deregulate, excuse me, which is a major problem. I'm sure there are people in the room who know how big a problem. It's absolutely huge. Suspend the need for X waivers. These are life-saving medications, and it's akin during the height of the IV drug epidemic in New York City, where I think 270,000 people were addicted to heroin. It would be akin at that time to saying you have to go through 50 steps to get any methadone, and if you're a provider, you can provide services to 25 people, and there's a cap put on you. You can't treat them. So it doesn't make any sense at all. Expand the role of pharmacists in identifying and treating, and this is one of our recommendations. Hence, the, shall we say, retail model of taking a major problem and solve it at the direct-to-consumer level. Encourage and leverage partnerships among prevention specialists, treatment providers, corrections personnel, and law enforcement, and you've got just the kind of coalition to do that, to ensure continuity of care for opioid use disorder upon discharge from jail, prison, and drug court. Without this, people, of course, slip back because this is such a gripping addiction, and it is a hijacked brain. It's a good way to describe it. Establish multi-site and multi-institutional collaboratives to really conduct all of the research that needs to be done. I won't go into this. This got a lot of airtime because it's a group of academics, no surprise. But we had the good sense not to overdo it, because while this is important, it is by no means the most important part of our recommendations. It is important, it's deeply important, but the on-the-ground recommendations are the most important. Modify the FDA review and approval process for pain medications. Discontinue the promotion of opioids for long-term use of chronic, not cancer pain, except for palliative and end-of-life care. Adopt the recommendations of the National Academy of Sciences for revising the cost-benefit framework. Approve an affordable, accessible form of naloxone. Impose post-market requirements on opioid manufacturers. Modify data resources and the Sentinel surveillance programs. I had a close family member who had never used an opioid, had surgery, took the opioids, called my husband and I, said, "Can you come over and help me remove my bandage?" We arrived there. 20 minutes later, she just came this close to coding. She was out cold. She was non-responsive for 15 minutes. My husband, well, he's a physician, was ready. He got things from her kitchen. He was about to trach her when the 911 responding people came in, and they were able to revive her. Turns out, someone who's opioid naive, and I'm sure there are people in the room who know this, the industry pushed the highest dose for initiation on multiple providers. And in her case, she was put on next to the highest dose. So she just simply OD'd, thank goodness, in front of me and my husband, because I don't really know what would have happened if we had not been there. But her surgery had been on her clavicle. It had just been repaired, which is why my husband hesitated to start CPR, but he was starting CPR and he was ready to trach her with household items when 911 came in. I was crying in the hallway. I was hysterical because she's like my daughter. So that's my personal experience with opioids, and I would never want to have it again. Here is our man, Ryan White, who was so brave when they burnt his house down. So he's not the first person. I'm sure there's an opioid user in the United States of America whose house has been burnt down. So we recommend a comprehensive program for treatment that is analogous to the Ryan White Care Act. You can look it up online. It started out, as something we all hoped would work out, and it turned out to be really probably the most model health program that the United States ever created and promulgated. Voluntarily end all lobbying and marketing activities related to opioids and other drugs of potential abuse. Fund, but not manage or control, one or more independent campaigns aimed at educating the public about the risks of opioids and the availability of treatment, because we know that 25 million Americans need substance abuse treatment and 2.5 are getting them. So the tip of the iceberg is getting them. Why it matters, just in a short period of time, somebody do the math, 8 years, we've doubled, basically almost doubled. We now have a total of 700,000 deaths. I think that closely approximates the total number of AIDS deaths. It might be a tad below, a few thousand. And so that's that. And then this is, I told you, 864,000 people a year, 32% of all deaths, really related to some key things we just can't get our arms around. Firearms, opioids, alcohol, obesity related to fast food and sugar-sweetened beverages, frankly, principally tobacco and carbon emissions, for which U.S. is not tracking, but the rest of the world is tracking. Some of you may know there was a case against Exxon trying to really pull them into a suit led by the New York State AG's office, and unfortunately they just had a killer resolution, so that case will not go forward. History of the MSA provisions, I've covered a lot of them, but this is just a sampling of some of the things that were done by the MSA. And most of the scholarship on the MSA say it was basically an equivocal success. And how can you say it's a success when 95% of the money went to fill potholes and everything but the epidemic it was created to solve? If that happens with this settlement, that will be the second public health tragedy that we've manufactured related to these settlements. And I, for one, will say, who wants to talk about settlements anymore? Because at the end of the day, it becomes, you know, the pork barrel politics playground for people who feel immune and unaffected by the problem. So, I mean, just to pick out some of the most important things, is the basis of the opioid claims, you all should know, is entirely different than the basis of the tobacco claims and provides a much stronger roadmap to a big settlement. The tobacco settlement was to pay back the states for money they expended to deal with the people who were ill from the tobacco epidemic and who died of the tobacco epidemic. Most of the cases in the opioid epidemic relate to public nuisance provisions and require a forward-looking solution. You have to solve the problem. So it's kind of hard to solve the problem without actually solving the problem. So that's a good thing. These are some of the things prohibited by the MSA. We luckily do not have opioids being sold with the equivalent of Joe Camel because there's not an active promotion campaign for opioids on the air. Opioids are promoted by the providers who have been deceived about them. And if you look at the court cases, you probably have. Delaware, Massachusetts, and New York are incredible reads. They read like a screenplay for a Hollywood movie. And in there you see the efforts that were undertaken to earmark a certain type of physician, a primary practice, a general practitioner, people who would not be skeptical and would not look to other sources to question what they were being told, who had a pattern of doing what the industry told them to do in terms of prescribing, and that's in fact what happened. So I mentioned already that the settlement, even though this did not involve money, dismantled the Center for Indoor Air Research, AKA do whatever you have to do to prove that no such thing as secondhand smoke effects exist. And they spent decades doing it and paying all sorts of people to prove it. The Tobacco Institute and the Council for Tobacco Research. They have now gone offshore and created the Foundation for a Smoke-Free World, which I think is a technical MSA violation because they're using it to make grants in the United States. And then, you know, many other things occurred. But the broken promise that the Center for Tobacco-Free Kids forever brings up is this line. Only 1.5 is earmarked for tobacco control. 106 billion since 2000. So it's really a fraction of the total settlement, which was 241 billion. 41 billion went to the lawyers. So they did okay. Imagine what an MSA could do. There are many things it can do. We talked about them. This is the epidemic curve. You've all seen it. It's extraordinary. It did fall last year by about 5%. This is the map I'm sure you've all seen. Every state has a problem. For whatever reason, now I'm going to get in trouble like the NPR reporter. Arizona does not have as big a problem as some other areas. I was surprised to see Utah where it is on this map in terms of hospitalizations. And then this is the consumption in Canada, in Europe versus the United States. So when we say we just really couldn't do anything about it, Europe managed to do something about it, just fine and dandy. Europe also, particularly France, because France had a spiking epidemic, and then they they made medically assisted treatment extraordinarily widely available, and they shut the problem down by and large. The industry put out educational messages. These are messages to providers. Physicians are needlessly allowing patients to suffer because of opioid phobia. Opioid addiction is rare in pain patients. Opioids can be easily discontinued, and opioids are safe and effective for chronic pain. My favorite, which isn't listed there, is that if your patient is appearing addicted, it's pseudo-addiction. This was made up by somebody who was on a faculty. He then became a vice president of Purdue, and he continued to peddle the concept of this is pseudo-addiction. What was the cure for pseudo-addiction? I'll give you 3 guesses. Can someone call out what the cure was? 2 words: more opioids at a higher dose. Hard to imagine that the Joint Commission, which they have acknowledged and admitted, could be dragged into essentially a conspiracy to defraud everyone admitted to a hospital and their families, but the opioid industry paid for pain as the 5th vital sign. It's bought and paid for, and they got it, and that's why when you're in a hospital, they ask you, which face is your pain? Pain is actually, up to a certain point, it's a good thing. You know there's something wrong with you, and at some point it's no longer a good thing. So I'm showing you this. It's been studied. The conclusions: evidence is insufficient to determine the effectiveness of long-term opioid therapy for improving chronic pain and function. Evidence supports a dose-dependent risk of serious harms. So the upside, very uncertain, and the downside, fairly dire. This paper is where we unveiled this report I just gave you the findings on, and that was in the Journal of the American Medical Association. You see me here as the lead author because the editor called me and wanted someone who had lived the tobacco settlement, and I spoke to my colleagues and we agreed I would lead this one. And basically we talked about much of what I've just mentioned to you today, and we lay out a new roadmap for addressing the opioid crisis in that paper. But some of you may have heard the news or seen it written in the papers, and I want to end here. I'm wrapping up, and we can have questions. The AGs, to my utter amazement, and when one AG told me, I thought he had just had 2 martinis or I had lost my hearing. But then when the 3rd or 4th one said, you know, Cheryl, we've reached a deal. We think we have a deal. And I think it involves about 30 to 35 AGs are comfortable with this type of a distribution, not the bottom number, but 15% of the funds to states to use at their discretion, probably weighted by the volume of the epidemic, 15% to localities, also probably weighted by the scope of the impact of the epidemic, which would have to be current and future predicted, which can be different, and then 70% to a central nonprofit to sharply curtail the epidemic from a central location. And an effort like that, 95% of the money should go out the door to grants, to organizations like many of those of you who are here in this room. The alternative is it will disappear into the coffers of state government, as the master settlement did. And you will have many legislators not happy with this paradigm. For those of you who watched the press coming out of the Oklahoma settlement and the swift response of the state legislature to remind the Attorney General's office that they appropriate dollars, not the Attorney General. So this can only happen by a gentleman and gentlewoman's agreement. It will be complicated if they cannot bring themselves to make this agreement. But I think it's a situation now that those who just decide to take the money and run away with it will be held accountable, and I could be one of them, but you are exactly the people who should be holding them accountable if this money is not used to shut this problem down. At 50 to 100 billion, it is a drop in the bucket of what the cost to date of the opioid epidemic has been in the United States. I don't have the figure right off the top of my head, but it's in a paper that I have coming out with the same people, Robert Pack and Sandra Galea, and it's in the hundreds of billions, multiples, I think something in 700 billion or something like that, and that is not counting productivity, which would, make it even vastly higher. So this is not enough to solve the problem, and because it's not enough to solve the problem, we need the Ryan White Care Act as well with federal dollars, and we need to make them all work together and understand that in the Ryan White Care Act, all the money, other than the money for the federal bureaucrats that are making it happen, go down to the local level. So you would have a private foundation that has the ability to be flexible and quick and responsive and not a nightmare bureaucracy, and then you'll have a fairly efficient nightmare bureaucracy called the whatever version of the Ryan White Care Act. I vote for doing the same thing. Find somebody, who's lost their life because of this, and therefore is sadly wrong term to use, but the poster person for this tragic epidemic. And I will end by saying happy to answer questions, and thank you all for all the work you are doing. It is vitally needed, and you are saving lives just by being in this room. Thank you.
Questions?
Is there a reason why there's law enforcement efforts, or can you talk about why that was excluded?
It was, well, we said it's not principally a legal problem, but it's not excluded. If you read the full report, it's definitely not excluded. For example, there's an awareness that localities have to be paid to get money to manage specialized drug courts, that there are circumstances in which someone whose crime that was committed while under the influence of opioids must be adjudicated, and it can't just go to a drug court because of, so that's very clear. The ability for law enforcement to have the means to reverse an overdose event. I have sat at multiple National Association of Attorneys General meetings, and I've heard law enforcement talk about the sunk costs they have had up to this point and how many things have had to be set aside to deal with this. So that is one of the big questions, and that's one of the lines of demarcation in a settlement. As I said, in the tobacco settlement, a huge amount of the money just went back to the general legislator, the vast overwhelming majority of it. And the reason for that was the basis of the case was pay us back for all these costs. So that is coming up in NAG meetings and in other forums, in National Association of Attorneys General meetings, because people are thinking of this as the same as tobacco. But the legal basis is not the same as tobacco, and you can't manage the nuisance if you don't solve the problem. And the problem now is so acute and so significant that you have to deploy money. And so I think the problem related to criminal justice that got the most airtime was the fragility of the moment of when someone leaves the system and goes back into the community, and the poor ties that exist there. Of course, I won't name a percentage because I don't know, but the percentage that could be managed through solely the treatment arm with appropriate social services and support, that is the better way to go, because in most instances, the crime committed was a crime associated with the addiction, which is true of many other addictions. If you think about motor vehicle accidents and alcohol use, there's a classic example, where people are charged, they go to jail, they don't get a pass. If they kill somebody with an automobile, the fact that they're a chronic alcoholic doesn't get them a free pass. The opioid epidemic is a little bit different than that, though I actually think there's an argument to be made about how you deal with that. Yes. Is there someone who wants to, do you want me to pick? Are you okay with me picking? Okay, go ahead.
So it's sort of two questions real quick. So in terms of people with chronic pain, right, I've been thinking a lot about this lately. And so a lot of the recommendations tend to be really about physician education, and the piece of data people are looking at is the number of prescriptions prescribed as the outcome.
Yeah.
But we know, right, that things like PDMPs, prescription drug monitoring programs, are actually associated with spikes in overdoses because of fentanyl and other things. So,
yeah, because it drives people out to the community to get their pain managed, yes. I'm well aware of that, and I should have mentioned it.
So in terms of, I think about this in terms of two populations of folks with chronic pain, right? There's people who might be experiencing chronic pain now, and new recommendations in physician education, right, is obviously good to try to do non-opioid where possible.
That's
but
right.
then there's all these folks that, because of what we're talking about in the crisis, have an opioid dependency, whether chronic pain is what. And I just don't think it's effective. And there's some people trying to do their own community-based research around suicides because of chronic pain. People have been forced tapered and cut off and all that stuff. I know Kalani was part of your group.
Yes.
I have some issues. So I guess just in terms of two populations of folks, if we force taper or cut all those folks off because of this stuff,
yes,
it's going to spike in deaths and suicides and other harm. and then there's other folks. And sorry, the second part.
I agree with you.
Did Safe Supply end up in your recommendations? I haven't read the full report yet, but in terms of things coming out of Canada, Europe, right, about like hydromorphone assisted treatment, heroin assisted treatment for people who all other options have failed.
I do not believe that is in the report, but I don't believe there's anything in the report that precludes it either, because one of the problems was the report was too long, and we wanted the report to, so I do not think, I never heard, I was at all the meetings, I never heard any preclusion, that being precluded. I did hear a great deal of skepticism about the pharmaceutical industry mantra. There are two going now that I'm aware of. One, we're, as they said before, we're well on our way to create a non-addicting analgesic. So we have to be a little skeptical about that. And then I think I may have just forgotten the other one, but it was oh yes. So some of you may have seen the paper in Science that shows this massive, almost exponential rise in opioid deaths, and basically the authors conclude that this rise was inevitable, and if it hadn't been this drug, it would have been another one, and that is false. And so there are a couple of different groups. We have one, and we have another one at the medical center trying to just prove the fallacy of that conclusion, because that's a conclusion that is going to be an important issue in these cases. Yeah.
Wondering, our subgroup has been talking about public education and all that sort of stuff. And we've been wrestling back and forth with the first age at which we should be targeted. Do you have any clear thoughts in your mind about how young is too young, or where you should start?
It's never too young. It's what message you use with the age. If you remember, the Surgeon General told parents to talk to your 4-year-olds about AIDS. He sent a letter to every home in the United States of America, and people were like, talk to my 4-year-old about AIDS. But of course, the message is a very different one. It's really more about the concept of an infectious disease. There is a campaign. I'm sure there are many at the state level. The Truth Initiative, which is the new name for the organization that I led for 15 years, they produced an opioid public education primary prevention campaign, and they have tested it as a heavy up campaign in Rhode Island. And I believe that the results of that campaign are under review now with a scientific journal, but I understand that it was impactful. And so I will say that they came and presented their campaign. This is confidential. I see you're taping it, but important people looked at their campaign who treat people with opioid addiction and were deeply disturbed. And then there was kind of a knockdown, drag-out discussion afterwards, because a primary prevention campaign looks entirely different than a treatment campaign. So a primary prevention campaign, the voice of the campaign was a woman, you've seen the ad probably, in a glass box in Greenwich Village, going through the discomfort of being treated for her addiction. She's not going without treatment, which was an important distinction. And on the box was information of where to go for treatment and all of that, even for people who walked by the ad while it was being shot, and it was left there for quite a while. It was occupied by the woman during the day for some number of days after the ad was shot. It was not the only ad. If you remember an ad where someone hits themselves with a hammer in order to be able to get a script, that was for a different group. That was for people who are already using and abusing and needing more. Abuse is probably the wrong word, So there is an ad campaign. This particular document recommends that there be a series of public education campaigns segmented, one for youth, one for the general public, anti-stigma, and one highly targeted to health professionals. And all the issues that you're mentioning, that's almost like a direct-to-provider campaign, are very important. And we have a big opioid use group at the college, and they have raised this issue repeatedly to me, and we're raising it while we were doing this. It's amazing that most people who read this report, though, focused on, would these recommendations keep from the dying rescue pain medication? People were obsessed by that. So we say it 5 or 6 times in the report. So, but this is an equally, if not more important issue that you're raising.
The DEA has a lot to say about, dispensing methadone.
Yeah.
So many of the requirements of the DEA stand in the way of dignity, stigma, I mean, perpetuating, relapse. I mean, there's just,
Yeah.
there's so many.
You mean standing in front of the provider and all that?
Exactly. It's
Yeah.
the indignities of it.
Yeah.
And in many ways,
Yeah.
when you talk about, having Matt available at CVS,
Yeah.
where did the DEA fall in your research or?
Yes, as I said, I always like to, confess, I was not the opioid expert at the table. I remember the DEA being discussed in some of the meetings, but I do not recall there being DEA-specific recommendations.
Barrier to much of what
Yeah.
we need to do.
I suspect, though, that the AGs in forming an agreement are aware of some of these DEA problems. And I certainly know the law enforcement agency, and I'm forgetting that I see we have people in law enforcement here who would probably know right off the bat, but the law enforcement agency responsible and held accountable together with the physician and the pharmacy for filling the illegal scripts, that monitoring agency isn't looking real good, obviously, any more than the CVS's and Walgreens, who are, both chains are named in most of the suits, nor are the physicians, some of whom didn't know better, and some of them just want to make a lot of money. Some of them are behind bars now, and more are going. Yeah.
So, if you think back to your experience with the whole tobacco process and leading up to the kind of results that you discussed with the distribution of the settlement funds, there's absolutely nothing to suggest that anything different will happen with the opioid as it relates to what federal and state government folks have generally been doing in terms of does the
Yeah.
magnitude of our response approximate the magnitude of the problem itself. So I'm wondering if you can comment a little bit on the advocacy strategies or the messaging that
Yeah.
occurred. Is there any lessons learned from the experience with tobacco that you would say, hey, be careful about this kind of messaging or this kind of approach? Is there any advice you would give us?
Yeah, there's a lot, and some of it is in this paper that's coming out in Millbank in a couple of weeks, in which we lay out what should be in the settlement and what the obstacles are to making it happen. That JAMA paper also has some of that. So let me start with the first part of the question, the assumption that there's really no hope on the horizon, that this isn't going to end up like the tobacco settlement. I do not believe it will end up like the tobacco settlement, principally because the AGs don't want the political problem. Normally, they want to say, here I am, I brought home the bacon, now you can spend it on everything, and now I'm going to run for governor, because NAAG stands for the National Association of Aspiring Governors. So this is something they want. They do not want to say, oh, your cousin and your brother's wife and that died, I took all the money. So they believe there is more sympathy in the community. I think they themselves have been at enough funerals to have this. So they don't want to own a bad deal. Let's start there. But probably the most important thing is these settlements have to be signed off on by a judge. And the judge has to follow the law, and the law says abate the nuisance. And you can't say, just give us 6 cents and we'll abate the nuisance. So the judge is going to be in an awkward position, the AGs are in an awkward position, and then for the second part of your question, if everyone turns their back, heaven only knows what will happen. So I think there has to be a consistent message that this outrage of taking the money and run can't happen again, even a little bit, which is why in both of these papers we really lead with all of this money has to go to solve the problem, and it will not be enough, because that's the truth. So if you have the same message, and I think, I'm sure there are states and localities who are unhappy with states and localities getting 30%, but what that allows is for the remaining 70%, and we're proposing a public sector board, which the Legacy Foundation had a majority public sector board. It had 2 AGs, 1 R, 1 D, 2 governors, 1 R, 1 D, 2 members of state legislature who were had health expertise, 1 R and 1 D. That was 6, and then it had 5 appointed public health members. So the elected officials had the dominant vote. They could come in one day. Giuliani said, shut that campaign down. What are you doing? They could walk into the next board meeting and vote to close the foundation and return the money to the tobacco industry. Literally, they could do that. They didn't, and of course I would have quit, and I wouldn't have let that happen. But the point is they were very powerful. And I would say that 99.9% of the time, the decisions were spot on. The money went where it should go. So, so that's much better than what can happen in a pork barrel feeding frenzy of 50 state legislatures. Yes.
Thanks for a great lecture. I was particularly interested in your model of involving pharmacies. And we've been doing a lot of work in our county with our pharmacies around primary preventative efforts and around tertiary preventative efforts. So we've gone in with our independent pharmacies to try to have pharmacists educate people that are getting first-time opioid scripts about the importance of taking as directed, not to share, and providing take-back envelopes that they can return.
Yeah, that's important, yeah.
We've also provided standing orders for naloxone to anybody that wants to come in. That middle piece, though, is what you're talking about. So identifying.
Where's in.
Right.
Yeah.
Identifying people that are currently having problems.
Yeah.
And referring them to care. Or
that's right.
I'm having problems with seeing how we would get pharmacists to be able to dispense without prescribing.
Yeah.
But
yeah.
First question is, do you have any models around the primary preventative strategy within the pharmacy that are successful? And my second tail to that is, we have found with the work that we are doing, we're not hearing about people going into pharmacies and asking for naloxone. It's widely available in all our commercial pharmacies now. People aren't coming in to ask for this prescription. So are harm reductive strategies, such as providing free needles, a way of having more people feel comfortable coming to pharmacies?
So do you think that in your community, the majority of people who are in need of that treatment are receiving the treatment, not the clean needles, but the...
I think we're getting better. I would defer to a couple of the other experts in this room, but I think that we have capacity and that we're getting better with having available treatment.
So, I mean, the general sense in the group that wrapped this up about 6 months ago was that it may be getting better some places, but it's still terrible in a lot of places, and that there was a need for vastly expanded treatment settings that were readily accessible. And on some level, I'm a little bit tongue-in-cheek when I say, why don't they do it? But I'm sort of not, because they're all reinventing themselves as health brands, and they're all opening up primary prevention, but mostly primary care settings, so that they can get into the pharmaceutical, dispensing and primary care business. And so I would say, join the club. You want to be in the primary care business? Give some primary care. So, I mean, in terms of models, some of those settings are taking on quite thorny issues, especially in communities where it's a long way to a doctor, and the closest one is at the shopping mall where there's a CVS with a primary care nurse. In fact, I know that a lot of them are called because people come in and we're having psychotic episodes, and they don't have the ability to manage them right there in the pharmacy, and they end up calling 911. So, I mean, I think one could learn the answer to that question. I don't have it for you, but yes, I think we have. Yeah.
Are insurance plans keeping pace with the solutions?
I have no idea. I really don't. I know that medication availability was a huge piece of Ryan White, and I know that that was a huge issue for this committee, but I didn't hear them discussing which drugs were readily accessible, which ones weren't. But we do know that we still have a substantial percentage of Americans that have no insurance. So, and many of the people who become ensnared in opioid use disorder have their whole life fall apart, so they're probably disproportionately among the uninsured. So, but I don't know the answer to that question. Yep.
I was a little surprised in reading through the report and recommendations that the cultural competency is mentioned in the foundational principles of the report, but we have not addressed the report. So are not addressed. We know, and I mean, I think the food campaign has been really great, but we know that there is a segment of society that has been left behind.
Yep.
And that segment of society is a segment that's, and I'm talking about urban, poor
And rural poor, yeah.
And that segment of society is already the segment that's suffering. And in terms of the opioid epidemic, they were experiencing opioid problems well before it became
Yeah.
something that moved out into rural, suburban and rural areas, and they continue. And if we're not careful in addressing cultural competency, we will just do the same thing, only worse, because now people are paying attention to it,
Yep.
and therefore it's even more stigmatized for that
Yeah.
population. So why, I guess I want to know, what was the ASB, PPH's rationale for not addressing this kind of what I think is the elephant in the room?
Well, there was, I think it's really interesting to hear that comment, and the observation you made, I missed. There was extensive discussion about that in the committee meeting. As a matter of fact, I would say that was the dominant theme.
But it's nowhere in
Yeah, and it may be because of the type of editing. I mean, they made it as one of the key goals. It's one of the primary foci for funding. They basically say that you have to fund the full range of social services, that you have to treat the entire family, that, many of the resources are going to be going to a broad range of individuals. They were very aware of diseases of despair, and when the epidemic curve began to rise related to the collapse of the financial markets and foreclosures and all of this. So there was an enormous amount of discussion. I do not know if when you go to the report link at ASPPH you can comment, but I would recommend, if you cannot, just to drop me a note and I'll get it to everybody on the committee. Because the report is the report, but there's nothing that stops them from correcting it and all talking points about it and making certain that it's like, for them, it probably was the elephant in the living room and they thought it was obvious to everybody, and you're correct, it is absolutely not obvious. So I think it's a very good point, and just let us know and we'll make some modifications, because philosophically, that's where the group was at. Yeah. Thank you so
Cheryl,
much.
the statistics prove it out that people are dying at an accelerated rate. And so this is really a timed event, right? So when you think about these settlements coming out of these class action suits, what's the time horizon where these monies start flowing into the communities? Do you have a view on that?
I don't, because I think a lot of it will be when all of the legal parties catch up with where the AGs are at. As you probably remember, a headline that said it's the United States of America, not the United States of Counties and Cities of America, which was like a shot over the bow from the AGs, because they do understand that they end up being often the ultimate settlers. So I think their feeling is, we've come up with a framework, everybody needs to come along and let's get it done. But there are a lot of interests, and a lot of those interests, I gather, actually are the interests of the lawyers who have been engaged by various localities and counties. So it's kind of, just imagine, it's like, I don't know how many lawyers like fighting among each other. So your guess is as good as mine, but I would certainly hope it's resolved in under 2 years. And I think I think a national opioid strategy, obviously there already was a significant appropriation that was put through the federal government. But at that time, that was not our idea. That was a congressperson. And I don't think it was Nancy Pelosi who really was key to the original Ryan White Care Act. But it was someone in Congress who said, we need that type of model. And we all looked at each other and said, that was correct. We do need that type of model. There's no reason to wait to do that piece other than look at what we're doing right now with Congress. I mean, no one's attention's going to be on it. So it is most unfortunate. Yeah.
Your statistic was 70,237,
Mm-hmm.
Center for Disease Control. That was a 2017 number.
Yes, and it went down 5% in the most recent year reported, and I believe that most recent year reported was 2018. So I have another slide that shows us a small decline there of 5%.
Well, that's significant.
So yeah, it went down. It went down, which is interesting because it went down in the face of clamping down on the prescriptions. But you do make a good point. That doesn't mean that the clamp down didn't cause some deaths at the same time. I've heard that in a number of places. Yeah. So, I mean,
Other drug use is going up.
pardon?
Other drug use is going up,
Which, of course, was the point of the Science article, so don't blame the tobacco, and don't blame the opioid manufacturers. They would have drunk themselves to death. It's really cynical conclusion. And not supported, I don't think supported by the data. But Any other questions? Otherwise, I'm going to catch my
Thank
train.
you, Dr.
Thank you.
Healton.